Okay, looks like we've got a fair number of people on here, so we can go ahead and get started. It's going to stay somewhat on time today. My name is Peter Katzmarzik. I'm the Associate Executive Director for Population and Public Health Science here at Pennington. And I'm happy to welcome everyone today to this third installment of our webinar series on understanding childhood obesity, which is co-hosted by Pennington Biomedical and the Louisiana Department of Education. So today we have three great speakers on this topic, followed by a question and answer period at the end. So what I'd like to do is briefly introduce each speaker, and then we will run the three presentations back to back, and we will come back together for a live Q&A at the end. So there's no need to wait until the end, though, to submit questions. Feel free to enter questions into the chat or the Q&A box, and I will record those, and then I'll be able to ask the speakers these questions at the end. So if you want to go ahead and do that along the way, that would be great. So today we have three great speakers as part of the webinar. Our first is Dr. Leanne Redmond from Pennington Biomedical. She will kick us off by presenting prenatal influences on childhood obesity, opportunities for intervention. Dr. Redmond is the director of the Reproductive Endocrinology and Women's Health Laboratory here at Pennington, and where she's also the Associate Executive Director for Scientific Education. Next, we're lucky enough today to have a guest from the West Coast with us, Dr. Pooja Tandon, MD, who is an associate professor and principal investigator from the Center for Child Health, Behavior, and Development at Seattle Children's Hospital. She'll be speaking on the topic of early childhood education centers in promoting healthy habits in preschool children. And finally, we have Dr. Amanda Staiano from Pennington. She'll talk about the treatment of childhood obesity in medical settings. Dr. Staiano is Associate Professor and Director of the Pediatric Obesity and Health Behavior Laboratory here at Pennington Biomedical. So again, these will be the three speakers, and then we'll break into a panel discussion and Q&A session following this. And again, I'll be looking at the chat and the Q&A box along the way, so I'll copy down all the questions for the speakers. So with that, I think what we're going to do is go ahead and maximize the screen on the presentations, and we'll just roll the first presentation. Again, welcome everyone.
Hi everyone, my name is Leanne Redmond and I'm a professor here at Pennington Biomedical Research Center, where I direct the Reproductive Endocrinology and Women's Health Laboratory. A lot of the work that we do is focused on understanding the intergenerational transmission of obesity, and we design and test interventions in and around pregnancy to improve outcomes of babies at birth and to improve their trajectory for health throughout childhood and later in life. So hopefully you know by now that our body size and many aspects of our health, including risk for chronic diseases, are passed to us across generations. And we care about this because as we enter pregnancy, there are a large number of factors that can increase the risk for a person to have poor metabolic health in their postnatal life. And then, of course, these people then grow up to become parents themselves. So we continue to pass on this vicious cycle and continue to contribute to the risk for obesity for future generations. So you're probably wondering where the risk for obesity comes from. Is it from mums or dads or both parents? Well, when we look at the odds ratio of inheriting obesity or high levels of BMI from our parents, of course, the highest risk comes from both parents. But when we look at each parent separately, we know that the greatest risk comes from the mother. So a lot of the work that is being done around the world is to try to understand these maternal factors that could be targeted for interventions to improve health, not only of mums, but also of babies. So I'm going to show you two little pieces of data before we get started. And the first one is just looking at the amount of body fat that babies have at birth, dependent upon whether or not the mother was lean or of a normal body weight at the time of pregnancy, or whether the mother was overweight, or whether or not the mother had obesity. And so that you can see in babies born to mums who were lean or had normal weight, those babies had about 11 or almost 12% body fat at birth. But as the mothers increase their size, or mothers that have increased body size, those babies have an increased amount of body fat at birth. And you can see with the little star, this means that it was statistically significant. And this device is called a Peapod device. And this is us here, and we have one here at Pennington. And we measure babies here in studies often and at a similar age here shortly after birth. But it's not body size that we care about all the time. You know, it's the consequences of having an increased body size that we really worry about. And those are the comorbidities such as insulin resistance. So what might be surprising to you is that at the time of birth, babies born to mothers that have overweight and obesity, these babies already have increased levels of insulin resistance when you measure factors such as glucose and insulin in the cord blood. And you can see that this resembles the insulin resistance that is measured in the mom. And the reason that we care about this is that in this particular study that they nicely showed that the degree of insulin resistance measured in the umbilical cord blood was in proportion to the amount of body fat that the babies had at birth. And of course, we know that if we start off on this kind of trajectory, it likely stays with us, right? And so in this particular study, they followed the children 4 to 6 years later. And they showed that the body fat of these children now entering kindergarten also resembled the amount of body fat that they had at birth. So we understand that it's really important for us to try to curb this vicious cycle as early in life as possible. So you're probably asking, is this the genes, is this genetics, or how much of this is attributed to the environment? And one of the best ways that we can answer this type of question is by looking at what happens in twins, right? So of course we have identical twins, which are called MZ or monozygotic twins, and these are individuals that have the exact same DNA. Then we have dizygotic twins. So these are individuals that are obviously in the same womb, but two different sacs. So they don't have the same DNA, but they share the same environment. So there's some really good studies that have tracked how BMI in twin pairs is different or similar dependent upon whether the twins were raised together or whether they were raised apart. So we would expect that BMI between twins that were monozygotic, so identical twins that would raise together, would be have the highest agreement with each other. And we measure that here with a value of 1.0. So a number that's closest to 1 would resemble that the BMI of the twins was very similar. A BMI that's furthest from 1, such as here, would show you that the BMI of the twins is different. So of course, as we expect, when we have the same DNA and we're raised in the same environment, we have the most agreement between the BMI or the body sizes of these two people. But then when the identical twins with the same DNA are raised in different environments, so these are adoption studies, you can see that the BMIs become more different. Now we have twins together in the womb, raised together, but different DNA. So they have different sets of genes from their parents. we lose some of the similarity in the body sizes of these twins. And then in adoption studies, now they've got the different genes and they're raised apart, and we've got the least amount of agreement between BMI. So we know that genes play a large role in determining somebody's body size, but they don't explain the BMI altogether. So the environment is also very important. So there are several ways in which obesity or body size has been shown to be transmitted from mothers to babies during the intrauterine environment and around pregnancy. So we just saw a couple of examples where the mother having a high BMI or increased body fat is important, but that's not the only story. We know that the quality of her diet in and around the time of pregnancy and the amount of weight that she gains in during pregnancy can have very significant effects on several factors that can influence the size of a person at birth. Very early in development, we know that these factors can influence the genetic material that exists actually within the egg and the genetic material that exists in those first few days following conception. So these things are called epigenetic changes. So after the genes from both parents have come together and there's a conception that's happened, these factors in and around the time of pregnancy can influence the way that these genes are either turned off or turned on. And of course, that influences the person's physiology, not only in utero, but also in postnatal life. We know that these factors can influence the placenta, how it grows and how it develops and how it transports energy or fuels like glucose and fats to the baby. We know that these factors can influence the composition of the mother's breast milk. We also know that they can influence the microbiome or these little microbes that exist within the gut of the baby. So there are a large number of factors that can be reprogrammed or influenced by the mother's size, the quality of her diet, and the amount of weight that she gains in pregnancy that can influence whether or not somebody has an increased body fat at birth and whether they remain on that increased body fat trajectory throughout their childhood. And the person that really helped us understand a lot of these factors is this guy right here. And his name is Sir David Barker. It's the late David Barker now. And he coined the Barker hypothesis in the 1980s, which is now known as the developmental origins of health and disease hypothesis. And this hypothesis says adverse influences early in development, and particularly during intrauterine life, can result in permanent changes in physiology and metabolism, which result in increased risk in adulthood. And Sir Barker went on to say that chronic diseases are unnecessary. He says that they are the result of the changing pattern of human development, and we could readily prevent them had we the will to do so. So isn't that interesting? And so when we come back to our original schematic about how body size is influenced across generations, the question really becomes, if we improve some of these factors in around the time of intrauterine development, can the trajectory of body fat development be altered? So this is where we spend a lot of our time thinking in the laboratory, is how we can attenuate this vicious cycle of obesity development. And we think about this from two standpoints. That is, are there interventions or things that we can do prior to pregnancy, prior to conception, that can improve the health of both parents, that would obviously improve the health of the eggs and the sperm, and also the health of the mother and the father at the time of conception. We then we recognize that more than 50% of pregnancies are unplanned. So we also think about interventions that can occur during pregnancy through lifestyle changes, so improving the quality of the diet, increasing the amount of physical activity to improve glucose and cholesterol and blood pressure and those sorts of things in the mum. And we try to design interventions and we test the ability of those to increase the health of the babies at birth, and throughout their childhood. So we're going to take a look at the evidence of intervening in these two time periods to see if we can actually think about altering the trajectory of kids in future generations. So while lifestyle interventions in the pre-pregnancy period are currently underway, so there's no real data to show you from these studies as yet, there is some good evidence from studies of bariatric surgery to show that if mothers have bariatric surgery between two pregnancies, that this leads to substantial improvements in the body fat or the risk of obesity in the children. So obviously, bariatric surgery results in a large amount of weight loss. About 30 to 50% of weight is lost after surgery. So in this particular study, it was conducted from the electronic health records. And so what they did was they looked at the body weights of children born to mothers, excuse me, before or after the mother had surgery. And they looked at the number of the mother's children that had normal weight, overweight, and obesity. So you can see before surgery, about 40% of the offspring of mothers were also having obesity. But after surgery and after substantial weight loss, you can see that there's fewer of the offspring of the mums with overweight and obesity, and more of the offspring were actually lean or had normal weight. So this shows that intervening prior to pregnancy is probably really important. And obviously bariatric surgery is targeted towards the mothers or people that have severe obesity. And so we really are awaiting the results of these studies of lifestyle improvement to see if these can have similar benefits for inducing a healthy body weight at birth and beyond for kids. So this is just a list of the different lifestyle programs that are occurring before pregnancy. Pennington is participating in one of these lifestyle programs. It's called LIP, Lifestyle Intervention in Preparation for Pregnancy. And you can see that we've been enrolling pregnant mothers here about 6 weeks after birth into a program for 2 years before they have their next baby. So we'll have to be TBD on the results of this particular trial. So I mentioned that there are a number of factors in pregnancy that can influence weight gain of the babies after birth. And one of those is weight gain in pregnancy. And you might not know, but there are recommendations for the amount of weight that a mother should gain in pregnancy. And these were published most recently in 2009, it's kind of old now, I know, but in 2009. And what you can see here that the recommendations for the amount of weight a person should gain in pregnancy have been determined on the basis of the person's size at the time of conception. So as you would probably imagine, heavier women are recommended to gain the least amount of weight in pregnancy in comparison to lean women. So if a mother is lean or has normal weight, the recommendation is for her to gain between 25 and 35 pounds during the pregnancy to support healthy pregnancy outcomes such as less risk for gestational diabetes, less risk for preeclampsia, less risk for preterm birth and these sorts of things, and obviously less risk for having a baby being born large for gestational age. But for a mother who enters pregnancy with obesity or a BMI above 30, she's recommended to gain between 11 to 20 pounds. And then you can see here that these weight gain guidelines have been translated into the amount of weight gain per week. So it's about ½ a pound per week after the first trimester. So guess how many women actually gain within these guidelines? It's only about 30%. So if we just took a sample of women in Baton Rouge, say that they all gave birth here at the Women's Hospital, 8,500 babies are born there per year, we would see that only about 2,500 of the 8,500 births would the mothers would have healthy or appropriate weight gain during pregnancy. And probably not surprising to you that the majority of mothers are gaining weight above these recommendations. But what we're concerned with most of all is that for mothers who enter pregnancy with overweight and obesity, a greater proportion of these mothers are gaining weight in excess of the recommendations. So we need to develop interventions for these women particularly that can help manage their weight gain. And so at Pennington, we designed an intervention to help mothers with overweight and obesity gain a healthy amount of weight in their pregnancy. And we participated in this very large national trial funded by the National Institutes of Health. And throughout the country, there were over 1,100 mothers with overweight and obesity enrolled in these trials. And you can see, in addition to the trial being conducted here in Louisiana, it was also conducted in WashU, in St. Louis, in Chicago, up in Boston, Rhode Island, also in California and in Phoenix. So this was a national-wide study. And so the goal of the study was, as I said, to increase the amount of healthy weight gain in pregnancy and to reduce weight gain overall. So what I'm showing you here are the primary results, gestational weight gain, GWG, shown in kilograms, and I'll translate it for you in pounds. But on average, if a mother with overweight or obesity was enrolled in a lifestyle program throughout her pregnancy, she gained less weight during pregnancy. And that was significantly less in comparison to the mothers that received usual care from their doctor. So this was total weight gain, and this is weight gain per week. And so we know that these trials that are focused on healthy diet and increasing physical activity can reduce the amount of weight that the mothers gain in pregnancy. But what about increasing or decreasing the risk of the babies being born with an increased amount of body fat? So we measured these babies shortly after birth, and I'm showing you the data here, similarly to the data that I showed you earlier with the PBRC. And you can see that the intervention group in yellow and the usual care group in blue, there was no difference in birth weight of these babies, and there was no difference in the amount of body fat that the babies had at birth or their percentage of body fat. So even though we were able to intervene in the mom and we were able to improve her weight gain in pregnancy, this did not translate to a reduction in birth weight or obesity risk in the babies at birth. So maybe we need to be looking beyond gestational weight gain, or maybe there are other factors other than weight gain or BMI to consider. Well, and our results of the Life Mums trial are pretty consistent now with other studies in the literature. So other studies with pregnancy lifestyle intervention trials, either doing diet, physical activity, or combined approaches, have found similar results. So you can see overall, these studies have found that the interventions can reduce the amount of weight gain. This is 10.1 kilograms in comparison to the usual care. But the difference in weight gain between these groups is really small, 700 grams, which is only about less than half a pound. And so the conclusion at the moment in the literature is that diet and physical activity-based interventions consistently reduce gestational weight gain across a number of different groups of women. And whether we look at age, the amount of babies that they've had, race or ethnicity, and pre-existing medical conditions, the results are really consistent. Their interventions have shown that they've improved whether or not the moms are more likely to have a C-section or not. So there's fewer C-sections if mothers are enrolled in these kinds of programs in pregnancy. But consistently, these trials have found no benefit to fat mass or adiposity measures for the babies at birth. So why is this? Well, the first, we think about two reasons. And the first reason is that these interventions really have very little specificity or personalization for moms. So we know that we need, in order to better manage weight, often we need a calorie goal. Well, calorie goals for pregnant women are really not well defined. So, you know, how many calories should women eat in pregnancy to gain a healthy weight, and what's acceptable? Well, the Institute of Medicine who made the report on healthy weight gain in pregnancy, suggests that in the second trimester, women can increase their calories to 340 calories per day, and they can increase their calories more in the third trimester to about 450 calories per day. But for women with overweight and obesity, there aren't any guidelines. So the ACOG, which is the American College of Obstetrics and Gynecologists, they endorse these guidelines, and then they add the caveat that says women with obesity may need fewer calories. Well, isn't that helpful, right? So we've got weight gain guidelines, but yet we can't translate these into calorie goals in order to give women better guidance on actually how to manage the weight gain in their pregnancy. So we conducted a study at Pennington to try to understand how many calories women with obesity need in pregnancy to gain a healthy amount of weight. And what we learned was that for women with obesity that did gain a healthy amount of weight, or the recommended amount of weight, so 11 to 20 pounds, they were actually eating about 125 calories a day less than they were eating before they became pregnant. So they actually in a calorie deficit or a calorie restriction type of state during pregnancy to have a healthy weight gain. So isn't that really interesting? And so when you think about the recommendations that we just heard from the Institute of Medicine, which was 250 calories a day in the second trimester, and 340 in the third, you can see that these sorts of recommendations would lead to excess weight gain. And that's exactly what's been found in all these prior studies that have done lifestyle interventions. And in order to gain the recommended amount of weight, women with overweight and obesity need to be eating less than 200. They need to cut their calories by 200 calories per day compared to prior to pregnancy. So the second reason why we think that the interventions to date have been unsuccessful is that one size does not fit most, right? So we've got these blanket recommendations for women with obesity, but it doesn't really consider other health factors or other metabolic risk factors that the mother may have. And so we know that not all obesity is equal, and that obesity that's also associated with high blood pressure, high amounts of cholesterol, and high sugar is more risky than obesity that is high body fat and a high BMI without these other risk factors. And these two these two different conditions can be referred to as metabolically healthy obesity and metabolically unhealthy obesity. And that is obesity that's when you have a high amount of body fat in addition to additional risk factors. So in our studies at Pennington, we measured this metabolic health of the mothers with obesity at the beginning of pregnancy, and we wanted to assess what happens to important factors such as glucose or sugar levels and triglycerides or lipid levels across pregnancy. So you can see that a mother who has metabolically healthy obesity, her blood sugar levels are consistently lower throughout pregnancy in comparison to the mother that has obesity plus metabolic risk factors. Similarly, for her triglycerides or her cholesterol levels, you can see that a mother with metabolically healthy obesity has significantly lower levels of lipids throughout her pregnancy in comparison to a mother who has obesity plus these metabolic risk factors. Now, this is really important because glucose and triglycerides are two really important fuels that promote growth of the baby in the womb. So you could hypothesize that babies born to these two mothers with obesity but different metabolic risk factors might be different. And that's what we wanted to test. And this is exactly what we found. So you can see, even though this study is small, it's just 14 babies, 6 girls and 8 boys. When we look at obesity, not as one size fits all, but obesity and metabolic risk factors, now we see that babies born to mom with obesity and metabolic risk factors, these babies are born with a higher birth weight and a higher amount of body fat. So now we can better tailor our programs to these individuals and families. So we know that obesity begets obesity. We know that this is a vicious cycle and that we need to intervene before pregnancy if we can in both parents, but if we can't during pregnancy to improve outcomes for the future generations of kids. So more research is needed to develop and test interventions with increased personalization and to improve public health strategies to overturn this intergenerational cycle of obesity. So I thank you for listening to our talks today, and I look forward to taking your questions in the break at the end of our session. Thank you.
Okay, I think we're ready for the second video now from Dr. Pooja Tandon from Seattle Children's Hospital. Thank you.
Hello, my name is Pooja Tandon, and I am a pediatrician and researcher in Seattle at Seattle Children's Hospital and the University of Washington. And I'll be speaking to you today about the role of early childhood education centers in promoting healthy habits in preschool children. I have no conflicts of interest to disclose, except I will start by saying that these two might be my only conflicts with this topic. These are my two boys that are now in middle school and high school, so much older than this picture. But when I was starting down this line of research, I had two children under the age of 5 who spent a lot of time in early childhood educational settings and really informed and inspired this work. So today we will first talk about why ECE settings, early childhood education settings, have such an important role in promoting healthy behaviors and the importance of those early childhood years for promoting health and healthy behaviors. We will review some best practices related to nutrition and physical activity, touch on screen time and outdoor play a little bit, and wrap up with the implications of the COVID-19 pandemic for these health behaviors. Now, 1 in 5 children ages 2 to 5 in this country is overweight or obese. That trend has stayed about steady for the last 2 decades. But fortunately, the importance of early childhood for promoting healthy behaviors related to weight status has become more clear and has taken on more importance in recent decades. Now, the importance of these early childhood years for weight status is that children who are overweight by the time they are 5 years old are 4 times more likely than their normal weight counterparts to become obese by 8th grade. And a third of obese preschool children will go on to become obese adults. Half of children who are obese in their school age years will go on to become obese as adults. So early intervention and prevention is very critical. In addition, there are disparities in obesity prevalence among preschool children. So this data is a little bit old, but it does show that preschoolers that are non-white, so the shaded in bars here, those are Native American, Hispanic, and non-Hispanic Black preschool children. They have higher rates, higher prevalence of obesity than white preschool children. And also children from families with lower income are also more likely to have obesity. So interventions in early learning settings are both important and necessary, particularly for the reason that almost 3/4 of children, preschool age children, are in non-parental care, in some sort of non-parental care on a weekly basis. And early childhood education centers are the primary child care arrangement for more than 7.5 million children in our country. They spend an average of over 30 hours a week in these settings. And so the the adult caregivers there have a critical opportunity to both role model and promote healthy behaviors. And these settings can be vital for public health interventions that address nutrition, physical activity, infant feeding, screen time, and outdoor play. This sort of summarizes what we're talking about, that the early childhood settings, both the formal and the informal care settings, present a tremendous opportunity to prevent obesity and make an impact that affects the trajectory of health for many children. There's also been an emerging body of research around the evidence base for the types of interventions focusing on nutrition and movement behaviors that focus on both environmental changes, policy changes, and programmatic changes in childcare settings. One of the most commonly known ones is Knapsack, which has a more recent iteration, Go Knapsack, with a robust website with self-assessment and resources available online. In addition, there's been research from around the world with evidence that interventions in early childhood education settings can work. Now, the CDC put out this spectrum of opportunities framework for state-level obesity prevention efforts for ECE settings. And this framework outlines how standards and support for ECE providers can at a state level, can bolster the nutrition, breastfeeding, physical activity, and screen time policies, practices, and environments. And they range from licensing regulations to quality rating and improvement systems, and also professional development opportunities and family engagement opportunities. So there is a website online, or links from the CDC website, with a PDF that goes into more detail about this framework. I also want to mention that interventions that focus on diet and physical activity are important not just for healthy weight status, but also other domains, including cognitive development. A few years ago, I was involved in a systematic review that focused on the literature for the relationship between physical activity and young children's cognitive development. And then we also looked at papers looking at diet and young children's cognitive development. And what we found that of the studies we reviewed, 10 out of the 11 that focused on physical activity found a positive relationship between physical activity or motor skills and positive cognitive outcomes. And all 8 of the diet studies reviewed found that a healthier diet pattern was associated with better cognitive outcomes. And some of the cognitive outcomes included were things like self-regulation, attention, working memory, and also academic outcomes like math scores and verbal scores on standardized tests. And I would say from working in this field, although obesity prevention and healthy weight was my initial sort of target and focus of work, I would say that for some stakeholders, focusing on cognitive development, early learning, and behavioral benefits of these health behaviors may actually get more traction. Now, we understand that many diet and physical activity habits and behaviors are established in early childhood before children reach kindergarten. So we'll speak about diet and the physical activity and related movement behaviors in turn. So let's start with why nutrition is important in ECE settings. So diet in early childhood is crucial for brain growth and development, and of course, physical growth and development. And children's taste preferences are largely established before 5. Younger children are more likely to try new foods than older children. And unhealthy diet is linked to numerous health conditions, including things like anemia, faltering growth, obesity, tooth decay, high blood pressure, and diabetes. And of course, prevention is better and less costly than cure. Now, when we look at the best practices recommendations for nutrition, they range across all of these domains, from both the content of what food is served to young children, food and beverages, feeding practices, and broader initiatives to support healthy eating and professional development, to create healthy environments and policies that reflect that. And while we won't have an opportunity to touch on every best practice in this talk, I wanted to highlight a few. So the early childhood education settings, particularly for infants, can play a critical role in supporting the feeding of breast milk for infants. And then as children get older and expand their diet, focusing on offering plenty of fruits and vegetables at meal times and snacks, healthy beverages, including having water accessible at all meals and other times throughout the day, offering whole grains, lean meats, and meat alternatives. And then in some other domains besides the content of the actual food, there's a best practice around having written policies for special occasion foods to keep those healthier, and the occasions by how often those happen limited. Some centers have adopted things like a kind of a monthly celebration where birthdays and other key events are celebrated on just one day, rather than the possibility of unhealthy treats coming in throughout the month, or restrictions around what type of foods can be brought in for special occasions. There's also a recommendation that food not be used as punishment or reward, no screen time during meals, and encouraging family style dining. Also, there's been a great initiative in recent years around farm to table practices in early childhood education settings. I'm going to shift to physical activity. This is my area of research focus, and we'll just start at the beginning. Physical activity is any body movement that uses muscle and requires more energy than at resting state. It can include things like exercise and commuting and chores for older children and adults, but for young children, physical activity typically takes the form of active play. Now, there's many benefits of physical activity for children that have been documented, from healthy weight status, like we've talked about, motor skills, fundamental movement skills, and also benefits to cardiovascular fitness, metabolic health, musculoskeletal health, and even things like mental health and ADHD symptoms as children get a little bit older. And certainly in school-age children, there's a robust evidence base around the relationship between physical activity and cognitive performance, grades, and standardized test scores. And this is important to point out because the increasing emphasis on early learning has sometimes led to decreased opportunities for physical activity for children. And I think that's where sort of bringing up or focusing on those cognitive and learning benefits can help make a case for making sure that physical activity opportunities are not limited. I'll also mention that early childhood or physical activity in childhood is related to adult physical activity. So children who learn those motor skills and confidence and joy of moving their bodies are more likely to become active adults. And certainly that can lead to numerous health benefits for adults. And for children who are active in childhood, though, there are, of course, benefits to them in childhood as well. So kind of multiple layers of benefit and trajectory of healthy habits and health from early initiation of physical activity. Now, what are the benefits of physical activity for children? What are the best practices for physical activity? And I'll mention outdoor time in here because a lot of the best practices talk about physical activity and outdoor time together. And so in this country, the recommendation is 120 minutes or more of physical activity for preschoolers in childcare settings. Some countries internationally have in recent years actually adopted 180 minutes per day of physical activity for preschool age children. And of that, 60 minutes or more is suggested to be adult-led structured physical activity for preschoolers. And I'll mention that both free play or child-initiated play and structured adult-led play is thought to be important because they may confer different benefits. Certainly child-initiated play allows an opportunity for social interaction, social emotional development, and fun and play in ways that may not be possible with adult directed play. However, adult-directed play can often be more inclusive if it's something the class is doing all together. If there's an adult sort of making sure that children who may not be naturally inclined to join an active play opportunity, that they also are being included, and provides an opportunity for the teaching of fundamental movement skills like throwing, kicking, balance, that are the foundational stones for later physical activity engagement. Daily outdoor time is another recommendation for preschool age children. And as far as time goes, I'll just mention that once children reach school age, the recommendation is 60 minutes or more a day of moderate to vigorous physical activity. And in our country, as children get older, the proportion of them meeting physical activity recommendations declines. And so again, early intervention and support of physical activity could be a critical strategy in children who are developing those movement skills, those motor skills, and confidence to engage in continued physical activity. Other best practices include limiting sedentary time, so outside of naps and mealtime, limiting kind of seated activities to less than 15 minutes per episode, making sure that the center has adequate space indoors and outdoors for active play, and that those spaces are accessible and for children with any special healthcare needs or limitations. And also to not withhold physical activity as punishment or use physical activity as punishment. And finally, including professional development and family education and family engagement around physical activity opportunities, and also having written policies for all of these. I wanted to briefly mention a study we conducted several years ago where we observed entire childcare days in the Seattle area and had a system for coding whether or not preschoolers were being presented with active play opportunities. And we divided it up into not active play opportunities, and then of the active play opportunities, whether they were indoors or outdoors, and kind of teacher-led, adult-led, or free play or child-initiated. And when we kind of aggregated our over 50 days of observation across 10 childcare centers, we found that 88% of the time, between not an active play opportunity, so where children were encouraged or required to be seated, or nap time, that made up 88% of their day. And so only 12% of the day, which translated to about 48 minutes, were actually active play opportunities. And most of them were in the kind of outdoor free play category, the recess type opportunity. So clearly suboptimal. And so, that really was one of the first studies that led me to then think about what types of interventions in childcare settings are important for promoting physical activity. And one of the most consistent correlates of physical activity in young children is outdoor time. So that's definitely been an area of focus for me in terms of a strategy for promoting physical activity is getting children outdoors, more certainly during childcare time, but even outside. Active outdoor play is beneficial for motor development. Often the surfaces that they're playing on are more challenging, more different than ones they encounter indoors. Loose parts, especially natural elements, pine cones, grass, sand can promote motor skills. Vitamin D levels certainly, and there's a growing body of literature around the additional benefits that nature contact. So when those outdoor spaces have elements of nature, that there may be additional benefits conferred. Some strategies that we've accumulated around increasing active play outdoors, adjusting schedules of outdoor time, recess time. There have been studies that have looked at different strategies, whether, one could be to just increase the amount of time that children are there. The other could be having children go outdoors more often. And there's some literature to suggest that children are more active in kind of the initial 10 to 15 minutes that they are outdoors. So how you break up that outdoor time could matter. So it's something to think about. Loose parts, as I mentioned, can make play more active and more fun, and also increase that interaction with natural elements. But even loose parts or portable play equipment, there's some evidence to suggest promotes more physical activity than fixed play structures. Having a balance of child-initiated and adult-led play. Appropriate gear. Here in the Northwest, we know that weather, rainy conditions can definitely limit opportunities for outdoor play, often be challenging for staff to also feel comfortable in those conditions. And in other parts of the country, I think heat and having shade could be critical for comfortable outdoor and active play. And then I think for centers that may be limited in the space they have, attached to their structures, looking for opportunities for nearby nature in local parks or trails that children may safely be able to get to. Also adding gardens or plants or centers that have done that just provide more opportunities for activities that children can engage in outdoors, and bringing natural elements indoors to increase comfort level for when children do get to spend time outdoors. I have one slide on screen time because I think that it's important to mention as we think about movement behaviors and sedentary time broadly. There are, of course, best practices recommendations for that. The American Academy of Pediatrics and the best practices for childcare suggest that there be no screen time for children under 2 years of age. For children over 2, the recommendation is to limit that screen time to 30 minutes a week at childcare. We do not want to use screen time as a reward. And any screen time that's used should be educational and commercial free. And finally, like with nutrition and physical activity, ECE settings can think about what types of professional development should be offered regularly, and family education opportunities around healthy screen time, and having written policies to support those. I want to wrap up with mentioning how COVID-19, how this pandemic has affected healthy behaviors and the ability for ECE centers to promote healthy behaviors. So there is certainly evidence that there's poor diet, sedentary lifestyles, and weight status, that the rates of obesity have increased for many during the pandemic, and also pre-existing inequities in access to opportunities for physical activity and healthy diet got worse for some families. In addition, with in COVID-related closures and restrictions, working from home, or essential workers needing to find childcare, there is more burden on parents and childcare parents and caregivers to meet children's needs. And of course, the pandemic was experienced differently by different families and different communities, and disproportionate burden, often on families that are already at high risk for health disparities. So supporting healthy behaviors in our ECE settings during the pandemic and beyond is critical and continues to be critical for health promotion, because the recommendations for healthy diet and physical activity have not changed, but it just has become more challenging for some to be able to meet those recommendations. We know that chronic and mental health conditions for children and adults have been are worse for many, and health disparities have worsened. So as we think about health promotion in ECE settings, this may also be an opportunity to support health equity. Finally, I'll just review some concluding thoughts here. Children in our nation face a range of health challenges. Many of them pre-existed, have existed from before the pandemic, and certainly persist. Promoting healthy diets and movement behaviors in early childhood offers the potential for promoting health and well-being and promoting health equity. And as we emerge, hopefully, from this COVID-19 pandemic, while we've had to think about considerations around, how do we promote healthy diet? How do we safely promote physical activity in our ECE settings? As we think about how outdoor spaces may be safer than indoor spaces in terms of infection risk, I think we have an opportunity to reimagine how our ECE settings are handling diet and movement behaviors, and opportunities to continue to be the place for health promotion and public health promotion for young children and families. I will leave you with this list of resources that are available online that have more detailed information around specific recommendations and best practices for diet and physical activity, screen time, and outdoor play, and may be able to offer guidance for those of you working in this space. Thank you very much.
All right, looks like we're ready to move on to our third and final presentation, and that'll be by Dr. Amanda Staiano.
Thank you for the chance to talk with all of you today. I'm Amanda Staiano, and I'm thrilled to be able to round out this session and hopefully bring it all together to talk about next steps in the treatment of child obesity in medical settings. As you've heard today, and as you're well aware, our children are at risk. Just 20 years ago, pediatricians would tell parents, don't worry if your child is carrying some extra weight. They're going to grow out of it. They're not going to grow up to be obese adults. But the data don't support that. We know that that's far from the truth. Most children with obesity do grow up to be adults with obesity. And many of these children are going to develop heart disease, liver disease, diabetes, and many other conditions and diseases, and at a very early age. So I'd like to show you some graphs of why this is important. I'll go through this quickly because I think I'm preaching to the choir here. I think you are all aware of how grave this is. But just to remind us all, these are a line chart to show the increase in prevalence of child obesity just over the past 2 generations. And you can see here among the preschoolers and grade school and high school children, the prevalence of obesity has tripled or quadrupled. We did some recent analyses that are under review right now, bringing the data all the way up to 2020. This is from NHANES, a nationally representative data set of children's height and weight. And you can see just in the past decade that that prevalence of obesity continues to increase. So a quick refresher, what is obesity? This is how we classify obesity for adults. And so based on a ratio of height and weight, we can categorize people as being normal weight, overweight, having obesity, or having extreme obesity. And you can see here the prevalence of obesity by state. We know here in Louisiana and in the Southeast, we have among the highest prevalence of adult obesity. Well, what about children? For children, we use percentiles. And so you can think about this kind of like standardized test scores. And so we want to compare children based on their peers of the same sex and age. So here is a growth chart for boys. And you can see here that a boy who has a body mass index of 23 at the age of 10 would be in the red category, which means that boy has obesity. If that boy's BMI was 21 at the age of 10, he would be considered as overweight between the 85th to 95th percentile. If that 10-year-old boy's BMI was 18, he would be considered in the healthy weight category. And so it's important to look at the percentiles here when we're thinking about overweight and obesity in children, and to remember that those kids above the 95th percentile are those that have obesity. And so when you look at this, we see from a few years ago, about 18% of children have obesity. Now, recent data show that over 20% have obesity. And again, here are the definitions of obesity. If you're interested in calculating your own body mass index or that for a child, you can go to the Pennington website as just one example, plug in these numbers and find out your weight classification. And so keeping that in mind, when we look at youth who have a BMI of over the 95th percentile, you can see once again that Louisiana and the Southeast have among the highest prevalence of obesity, well over 20%. And similarly, we see high numbers among preschoolers, although fortunately it is a bit lower, but still over 10% of our preschool children, in particular, these are WIC participants, have obesity. And Louisiana consistently ranks among the top 5 states for child obesity. And so this is a significant issue here as well as throughout the country. I also wanted to share with you these charts to show data just in the past 2 years. And it's clear that with the COVID-19 pandemic, the restrictions, declines in physical activity, interrupted sleep, changes in nutritional habits, and children doing remote learning and away from school, we are seeing continued increases in obesity prevalence. And in fact, these are data that are pulled from large databases of patient charts, electronic medical records. And we see over the past 2 years that month by month, children were gaining twice the amount of weight as normal before the pandemic started. And this has been particularly high among those children who already had obesity. And so it's certainly a significant concern. We know that many parents, 88% of Louisiana parents report being concerned about child obesity. And we know that there's real financial and economic cost to this. Lost productivity, lost wages, absenteeism, having to take children out of school because children with obesity tend to have more doctor's visits and medical complications. We know the medical complications of obesity can start as early as childhood and adolescence. And here's a graphic that shows you how obesity affects just about every organ and organ system in the body. And so from the psychological consequences of stigma and discrimination to the very real physiological complications of extended inflammation, of the heart disease, the diabetes, 13 different types of cancer that have been linked to obesity, asthma and sleep apnea, and on and on. And so it's a significant issue, but I'm here to share that we do have treatment options that are becoming increasingly available and that have evidence to back them up for helping children and adults with obesity. And so you may hear from us at Pennington Biomedical Research Center and other scientists and doctors that obesity is a disease. And it truly is. It's a complex and chronic disease, just as we would think of heart disease or cancer or lung cancer as a disease. And here's a quick timeline to show you that, back in the 70s, there wasn't this recognition of obesity as a disease. Now, there were scientists and medical providers that recognized obesity, but in general, the health insurance companies, the policymakers, the public thought that obesity was a matter of willpower and individual choice. And so there was language put in a lot of health insurance plans that specifically excluded obesity treatment from coverage, whether that's medication or behavioral therapy, which I'll talk about, or surgery. And so the past 50 or 60 years has been spent trying to undo some of those exclusions to try to increase the tools that doctors have access to and the options that patients have to treat their obesity. So the National Institutes of Health in the 80s and the 1990s released guidelines considering obesity as a disease. The Internal Revenue Service recognized obesity as tax deductible for treatments related to obesity around that time. There was other movement, including the Center for Medicare and Medicaid, but there was continued pushback saying that obesity is not a disease, and yet surgery was being covered. But finally, there was more momentum about 15 to 20 years ago. The Obesity Society came out recognizing obesity as a disease, and ultimately in 2013, the American Medical Association recognized obesity as a disease. So why is this important? Well, for patients to have treatment options, for those treatments to be covered by insurance, for the doctors to be trained and to be able to provide services and help and support for people with obesity, it was very important to recognize obesity as a disease. So now that it is, I'd like to go over the treatment recommendations for child obesity. This dates back to the year 2007, when the American Medical Association, with support from the American Academy of Pediatrics, released some expert guidelines for child obesity, which I'll share with you today. These were then supported in 2010 by the U.S. Preventive Services Task Force recommendations, which is what I show on the left, saying that providers should screen children for obesity, and when they have obesity, should offer or refer them to intensive counseling and behavioral interventions to improve their weight status. And this was, again, another evidence review was done in the years after, and this recommendation was repeated in the year 2017. And now this body of evidence is once again under review, and some new guidelines are expected to come out shortly. I'm also part of the American Academy of Pediatrics committee to update the clinical practice guidelines for pediatricians for child obesity. And there are similar guidelines from the American Psychological Association and from the Nutrition and Dietetics Associations. And so all of these associations are supporting one another, looking at the evidence to see what is working in clinical and medical settings and what should we be supporting and endorsing. And so this comprehensive behavioral treatment is what has the most evidence to date, and I will describe that to you now. So for both children and adults, behavior change intervention is really the foundation for a lot of these treatments. So even if you ultimately prescribe medication to treat obesity, have surgery to treat obesity, changing the habits, the nutrition and diet, the physical activity, even sleep, is foundational to helping people to lose weight and to maintain that weight loss. Now, it's not as simple as just asking or telling people to make these changes. People are living day to day in an environment that is pressuring us to choose unhealthy options. And so when we work with families, as you'll see in a moment, we're really thinking not just about that child and that parent, but we think about the household. We think about the school, what sorts of foods are being provided to the child at school? What's the parent consuming during the workday? What does their work schedule look like? We talk about the neighborhood, we talk about siblings and other family members and friends in that child's life. And so we're really trying to figure out what are all the environmental triggers and factors, and how can we help that child and parent to navigate all of these choices to ultimately get to a healthier weight. So I'll touch briefly on the different recommendations from the American Medical Association. As I noted, these are being updated in the next year or two, so keep an eye on this space. But there's some really good recommendations here, some coming from expert consensus and some coming from the scientific literature and evidence. And so it's recommended that physicians, pediatricians, nurses, dietitians, when they're working with a child and with a family, they should be assessing behaviors. There are some simple questions to ask about, for example, soft drink consumption, about sleep, about physical activity, fruit and vegetable consumption. And all of this feeds into prevention counseling for every child, regardless of their weight status. A lot of resources are available on the American Academy of Pediatrics website. So if you're interested in this, I encourage you to go to that website. You can download a lot of really great free one-page resources to give to patients, to give to parents, or to use for yourself. And it's also recommended that the healthcare provider takes height and weight in an accurate manner. There are recommendations for how to do that. And then, as I showed you the BMI chart earlier, plots that, and the electronic medical record will automatically plot that for kids and parents. And as I showed you earlier, there's color coding available too to help families realize your child's in the red zone here. And not only is your child in the red zone, but you can see over time how that BMI has gone up and up and up over the years. We want to get that child into a better trajectory, a better path. And so these are the main items that are focused on actually in the doctor's office during the doctor visit: the behaviors, the prevention counseling, and determining the weight classification. So if the child has a healthy weight, then you still would do a family history, review systems, physical exam, and if the risk factors are absent, it's good to provide continued prevention counseling, because even children with a healthy weight, many of them do develop obesity later in life. So it's important to establish those healthy habits now. If the child is overweight or has obesity, it's important for that healthcare provider to determine if there are risk factors present. And so what do I mean by that? Well, all children should be getting lipid profile starting at the age of 9 to 11 and then repeated 10 years later, even if they're healthy weight. So we want to see, is their cholesterol at a healthy range? For those in the overweight and those who have obesity, it is even more imperative to look at lipids and to do a blood draw. We also want to make sure that that child's tracking on with their weight velocity. And so if we start to see that their BMI is shooting up or shooting down all of a sudden, we want to dig in and try to figure out what are the triggers for that, what is to explain that. Now, if risk factors are present, I won't go into great detail here, but there are a lot of tests, screening tests that are recommended to see whether that child is already developing some of these other diseases, these comorbidities. A lot of these can be done non-fasting. Some of them do require fasting. The A1C is recommended as an easy point of care test that does not have to be fasting. But there are a lot of signs and symptoms that can be picked up just during a physical exam or through that blood draw, as well as anxiety and depression and some of those invisible illnesses that are very important. Talking to that child to see if they're being bullied at school, for example, or bullied online. So there's a lot of great resources out there for healthcare providers and parents who are interested in this. And then ultimately, it's a staged approach. So there's some things that that doctor or that nurse can do in the office related to prevention counseling, but gradually or even quickly, we're shifting children with obesity into a more structured program where they're going to be meeting regularly with a dietitian and with a trained therapist to help the parent and the child to change their habits and attain a healthier weight. The Prevention Plus is the first stage. This can just be 15 to 20 minutes in the doctor's office. We're training doctors to do this now, and possibly encouraging that family to go see a fitness trainer or to go meet with a dietitian or a nutritionist. Next is the structured weight management, where you're going to bring in a dietitian to help that family create a healthy eating plan, to think about what they're purchasing at the grocery store or the corner store. How are they cooking and preparing their foods? What portion sizes are they giving to their child? But ultimately, most of the evidence supports this stage 3, which is a comprehensive multidisciplinary intervention. Oftentimes, this is only available in children's hospitals, tertiary care clinics, but through the work of myself and colleagues around the country, we are working to get these programs into primary care offices so that that family can go see their pediatrician or their general practitioner, and also have the dietitian or the social worker or therapist right there available to them to provide the program and support, or to use telehealth and video visits, especially for families who may not have access to a dietitian. This could include a behavioral counselor, like a psychologist, a social worker, someone potentially trained in exercise, and a dietitian or someone trained in nutrition. And then the final stage, which is recommended for many adolescents, especially those with severe obesity, is to consider medication and surgery. And so I'll touch on this briefly. But again, that behavioral treatment really provides the foundation for moving forward into potential medication or surgery. Some of the medications that have been approved recently and used for children include phentermine, orlistat, and liraglutide. There are new medications coming online in the last few months and going forward, but in general, this is an area of great need. We see children and adults can sometimes lose 5 to 10% or more of their body weight on these medications. Some of them do have side effects that need to be considered, but it really can be powerful to help children and adolescents to achieve some weight loss milestones, as long as it's coupled with that behavioral support. And one note here is that if you look at the equity among the different diseases, over 200 drugs for cancer have been approved, over 100 for cardiovascular disease, neurological disease, but only 6 for obesity. And while that is rapidly changing, I think that number is already out of date from a year or two ago. It shows just how much more research and support needs to be focused on this area to give people the best chance of success. And so we do offer metabolic and bariatric surgery here at Pennington Biomedical Research Center in partnership with Our Lady at the Lake. And that's the Metamore Institute, which is available online. And there are other surgery clinics around the country that will perform surgery on adolescents if they meet the eligibility criteria. So my final few minutes, I'd like to talk about the family-based behavioral treatment, which is considered a gold standard of treatment for child obesity. It's a standardized intervention. There's a curriculum that comes along with it. And this is what we've been teaching and training providers to deliver and plan to continue disseminating it. It includes the family. So you are required to have a parent and child present at these sessions. We encourage the whole family to be involved. So this could be siblings, this could be the grandma or the aunt, whoever's involved on a daily basis in that child's life. We've seen through the evidence that the more contact hours, the more dosage of this behavioral interventions, oftentimes the better the outcomes for weight loss. In addition to teaching about nutrition and physical activity and doing some hands-on instruction, it also includes parenting skills and behavioral therapy techniques like goal setting to help that child and family to change behaviors. And we don't want to single out just one child in the family. Even if that one child's the only one who has obesity, this is a family commitment. So we need everyone on board. We talk about self-monitoring through either paper logs or digital logs and apps of nutrition, of what they're eating, periodic weighing, their physical activity. We talk about setting SMART goals, specific and realistic, that we can track over time. and making choices and making sure that the children have choices, that they learn some autonomy, but that those choices are really focused on healthier options. We are working to get FBT into the primary care setting. We've got a number of research studies doing that right now, and we're setting it up for future dissemination so that once the research study is over, these providers can go on and continue offering these services to families outside of research. As I said, family engagement is very important. Those parents are often the gatekeepers for the child's eating and physical environments. And so we oftentimes see that parents are losing 20 pounds or more by participating in these programs. We also teach providers motivational interviewing techniques. It doesn't work just to tell families you need to do X, Y, Z. You really need to work with them and understand what sort of goals do they want to make and do they think is feasible. And let's start with just 1 or 2 simple goals and see how that goes before layering on more. This is all about behavior modification, which is what this slide discusses and I've talked about earlier. Here's an example of goal setting. We use the traffic light diet. The red foods are the ones that you want to be mindful of and keep count and try to start reducing. The green foods, those vegetables you can eat when you're hungry, grab a green food. And this is sort of, an idea of how we're trying to start moving people towards reducing the calories that they're consuming and increasing their physical activity. We talk about stimulus control. What are we serving and have available in the household? What are we seeing on a daily basis? What are we putting in that child's lunchbox, or what do they see in the cafeteria? And of course, self-monitoring, as I mentioned, is really one of the linchpins of success. So helping people to monitor what they're eating and how much they weigh. Here's an example of the curriculum where we'll start off with a few weeks focused on healthy eating, move into physical activity, talk about establishing healthy routines, and then ultimately maintenance and social facilitation. Obesity is a chronic disease, but we want to equip people with these skills because they're going to potentially be struggling with this for years and years. And so we want them to feel confident and competent so that once they're done with the program, they can continue implementing this throughout their life. Here's an example of the traffic light eating plan. I don't have time to go into great detail here, but you can see how we try to make it really simple. It's not about counting calories, but it is about tracking what you're putting in your mouth and how much physical activity you're getting. And then here's some examples of the other curriculum that we go through to try to surround that child with support from their peers and their families and so on. So in summary, I've talked about the behavioral intervention for the treatment of obesity. There's a lot of really exciting, promising work for the medical treatment of obesity. Keep an eye on this area because more guidelines are coming out, more resources, and insurance companies are stepping up to the plate as well to cover these services. So we're really thrilled to see this. In closing, I want to thank Sydney on my team for helping to prepare these slides, a number of my colleagues, and the funding from the CDC and PCORI. And you're welcome to reach out to me at any point to talk with me more. We're excited to bring these programs throughout the state of Louisiana, throughout the country and beyond, but we really need your help as advocates. So thank you for your attention, and I look forward to taking your questions and for the panel discussion.
All right. Thanks, Amanda. And if you guys want to go ahead and turn on your cameras, if it's okay, we have Amanda here, Pooja. We also would like to introduce Dr. Joshua Sparks. Joshua was a postdoctoral fellow working in the laboratory with Dr. Redmond, and he is here to address any questions you might have related to her presentation. She got pulled away on a bit of an emergency. So she won't be able to join us, but we will definitely keep track of this. Also, we've had many people who registered for the conference or webinar that couldn't make it today. And just be assured that this presentation will be recorded. Actually, it is recorded. And we will be editing it and making it available. It'll be sent to all attendees who registered for the webinar. Also really like to thank Dr. Tandon for coming all the way from the West Coast to join us today. It was very nice to see you. And so we have Amanda, we have Joshua and Pooja all here to answer questions. There was one that was typed in the Q&A box. I believe it was directed to Amanda. It is, how do you convince state Medicaid agencies that dietitian services are important and they should be billable? I'm sure you faced this.
Yeah, we could spend hours talking about this, so please reach out to me separately. There's a lot that can be done, I think, at the state level and national level. Of course, every state has different Medicaid plans and requirements. I think one area we could focus on is when the state releases their applications every couple of years to ask the state to include specific language about obesity coverage related to dietary counseling. So that way, as these plans are applying to be the Medicaid plans, they're required to have a plan in place. I will say though that we have had a lot of great luck here in Louisiana with getting the dietary services for pediatric obesity covered by these state Medicaid plans, but the rate of reimbursement is quite low. So financially, it may not be sustainable for the clinics. But you see that in New York, you see that across the country as well. And then we're also doing work at a federal level too. So even though each state has a lot of authority on their Medicaid plans, there's a lot of interest at CMS, Medicare and Medicaid, and the CDC. And actually just last week, there was an announcement that all federal employee health plans are required to provide obesity treatment services and coverage. And so that's going to cover a lot of children and families throughout the country. And that's what it takes, is some models like that, as well as showing the evidence that this is effective. This is helping families to lose weight. And so there is a great return on investment.
You know, I was struck in listening to all the presentations that, you know, we tried to cover the life course of a child here, and just to listen to Leanne's presentation about having interventions that start even pre-conception and then after conception during the gestational period, and moving into early childhood with the early child care education settings, and then now moving into the medical settings with school-age children. We see, you know, we see effective programs in all three areas. In some cases, the effects are greater than others. And I guess we have to balance that a little bit with the long-term effects and what we're going to be able to do at a population level. You know, versus working with an individual versus trying to implement some sort of population level intervention that would affect more people. So I don't know if any of you have comments on that as to how we can scale up some of these approaches, you know, in all three periods of the lifespan we talked about.
I'm happy to jump in. Hi, everyone. Yeah, I mean, I think that's really a question I've wrestled with in my career. So I'm a pediatrician, I'm a primary care pediatrician, and kind of went the other way because I felt like, you know, what we could accomplish in primary care, pediatrics, kind of on an individual or family level, especially, you know, when I kind of first got into this work 10, 15 years ago was so challenging. I mean, the resources around it, and even before we had all the evidence that now supports that, how intensive multi-level, you know, multidisciplinary interventions are really what's needed to make lasting change. I kind of experienced that in practice, that what I could do in the context of a well child visit or subsequent follow-up visits was very limited. And to me, that, you know, that was sort of a compelling case for finding children where they were spending most of their time and most of their waking hours. And so kind of the early childhood education settings, and then now I have some work focusing on kind of elementary and middle schools as well. As my kids get older, I find, you know, new settings that are more compelling to me. But I mean, you know, jokes aside, I really thinking about, you know, where children are spending time and where we can focus at least the prevention aspect, you know, primary prevention, secondary prevention, in terms of making those healthier habits easier to adapt, both from the diet and physical activity standpoint. So and then some of the evidence coming out that those intentional approaches and interventions in those settings can be effective has been helpful to know. But of course, we need something at kind of all of those levels, and we need the treatment approaches too for children that are there.
Yes, no, and thank you very much, Dr. Kaczmarzyk. If I can add on a bit, I mean, within our trial, one of the key things is like you said, that scalability, how you get to this population level. And so one of the trials that we have ongoing within our lab is our Smart Moms and WIC program, which is a scalable mobile health trial really embedded in Louisiana women, infant, and children setting. And so it really is trying to reach, vulnerable populations in a much larger setting based in science, and what we've seen has been able to be done in our lab in a much smaller base. So one of the key things is, garnering the ideas, the needs, desires, wants of the population in general, but then learning what's going to work and how to implement that in a meaningful way that's going to be appreciable by a large population. And that's kind of what we're hoping to do. So definitely stay tuned, at least in the pregnancy world. We're still a bit away from the preconception, but we're working towards it. But within pregnancy, yes, scalability is one of the key things in trying to reach this population level is very important.
And then I'll just add on, I think we all recognize investing in prevention is so important, because as you go along treatment, it becomes more and more expensive and time consuming. And like Pooja said, some of the programs we're testing, we're trying to make it more pragmatic, but a lot of the doctor's offices don't have the resources or staff to deliver this. So like Joshua mentioned, between mobile apps, telehealth, and video visits, a lot of that can help to at least increase the access to more and more families. But it is definitely a problem. But one way I think about it is, even if you're talking about maybe a 15, 16-year-old adolescent who needs bariatric surgery, that might cost $25,000, which sounds like a lot. But if you don't intervene, and if you don't have that, help that adolescent shed the 50 or 100 pounds extra weight, think about the lifetime costs that'll incur, not only for that person's quality of life, but if they develop heart disease and a heart attack, diabetes, cancer, et cetera, the cost of obesity treatment really pales in comparison, and that can help set that person on a much healthier trajectory and avoid all those other diseases.
Just sort of as a follow-up, something we all deal with, and this is a question that we just put in the chat. How do you approach families who recognize the risk in their child and the fact that their child has obesity, but they're reluctant to change their lifestyle or their behavior in support of their child? They recognize there's an issue, but they really don't want to do anything about it. We encountered this certainly at the state level in trying to put in policies related to physical education and recess, these sorts of things that people recognize it's important, they're reluctant to do it. Any thoughts on how you might work with families? Have you seen that in Amanda, in your trial at all?
Absolutely. And I'd love for Pooja to weigh in here too, because she's certainly our physician expert here. But we see that oftentimes. And what we're trying to do with our trials is make sure we're not only getting those families that are highly motivated, ready to lose weight. We want to try to reach the families that are a bit hesitant or may not realize, my child is not going to grow out of this, or this is something that we need to tackle as a family. So we basically try to work with physicians to pull at any string that's available to them. So it's oftentimes the parent themselves have obesity. Many times, maybe they have diabetes or other issues, or they're having joint issues and knee pain. So we try to kind of pull at that string and see if that's something that they recognize. And oftentimes that is a motivator for them, because they don't want their child to go through the same experience. Or if we can just talk with them, and we use motivational interviewing techniques, like I mentioned, to figure out, is there some small habit that they recognize that they might be willing to change, or what is it that they value and that they're coming to talk about? Maybe they want more time together as a family or something. And then sometimes it's just not the right time to talk to families. And if you push them, that relationship with the doctor is really valuable, especially with the pediatrician. So sometimes it makes sense just to talk about whatever issue the family is really concerned about, to continue building that relationship, and that to hope maybe the next visit there'd be an opener to start that conversation.
Yeah, I agree with everything Amanda said, and was thinking about, motivational interviewing really is the crux of what we will try to use in primary care, and what we'll train our, sort of the students and trainees that are coming through is trying to first establish, what is the willingness to change here? And it might be something as, there are some evidence-based strategies and tools out there. One of which is kind of using this scale, like on a scale of 1 to 10, how likely are you to, do something, whether it's related to physical, like make a change. And if they answer 3, following up with something like, oh, I'm curious why it wasn't a 1 or a 2. So trying to like spark something there about, well, it wasn't 0. So there's some motivation there. So what is it? And can we kind of work on developing what it is that's driving maybe a little kernel of desire to make a change? And then in the context of kind of, a brief 20 or 30 minute appointment that we might have, I try to think about, maybe 1 nutrition goal and 1 physical activity goal that a family can focus on that they come up with. So yeah, try and linking it to something that they value, and it may not be weight loss. And one thing I mentioned in my presentation, that this is not at an individual level necessarily, but in some of our kind of preschool based interventions, we focus a lot on early learning and cognitive outcomes, and children who move learn better and they behave better, because we just found that, trying to say that like this is all about obesity prevention was not kind of high enough priority for many that we encountered in the early childhood education community and policymakers. And they recognize it's a problem, but not something that's going to motivate them the way that the standards that their school is held to, which often has to do with kind of child like educational and behavioral outcomes. So sometimes finding, whether it's speaking to stakeholders or finding a policy lever, or at an individual level, how does this connect to something that is potentially more motivating than weight status?
Thank you. So not to put you on the spot, Joshua, we have a question here. If you could comment on the best approach. This is a big question. What is the best approach at stemming childhood obesity based on starting in the womb?
What is the best approach to childhood obesity starting in the womb? Well, really, what I think the best approach for your question is to start before the womb. But if we are going to sit there and we're going to try to tease apart what's going to be most impactful within the womb, we really need to focus on the precision medicine, like the paper from Emily Flanagan showed, where it's about the circulating biomarkers that help fuel this infant growth in the in utero environment. It's the cholesterol, it's the triglycerides. If we can really identify those people who might respond to certain types of interventions in these fuel sources and substrates that are really used to fuel the infant growth, maybe we can actually impact the in utero environment and in the womb to really impact the future development of childhood obesity. So I think really it's about personalizing and understanding what the risks are for the women who are pregnant as early as possible in order to develop approaches that are going to be most beneficial. So it's a roundabout answer to say, no, I don't have an answer, but I do think it's going to be based in what we have available to help us prescribe and then in turn adapt these programs in order to meet the needs of the person.
It is very tricky, isn't it? A lot of times a person won't even know they're pregnant until they're well into the first trimester or beyond even. And so, it's very hard to start that early.
Yeah.
Unless, if it was a very much planned pregnancy and they're able to do kind of preconception interventions.
Yep. And so that's one of the key things that Dr. Redmond highlighted, is that the majority of these pregnancies are quote unquote unplanned. And so the time frame and actually being able to target earlier in pregnancy might be more difficult. So yes, it is a difficult time period to really account for, because within the programs that we have, we recruit women specifically earlier in pregnancy, but we do miss out on some women who don't find out they're pregnant until much later. They're in the 15, 16 weeks gestation. And so for those women, it is a bit more tricky. But one of the good things is that utilizing a lot of the information that we know is that preconception at least health as far as some of these circulating biomarkers don't traditionally change an extreme amount leading into the first trimester. So we can utilize some of the metrics that we have earlier in order to help inform later during pregnancy as well.
We've actually been kind of shifting our thinking, Joshua, when we're working with adolescent girls. Certainly we want to try to improve that adolescence obesity, but we're really thinking about the next generation as well, if we can get them healthier before they enter pregnancy.
Yes, that's an excellent point, is that now, yeah, we're trying to get them now. And so I think really it's the earlier, like you said, it's that adolescence, it's the health during the reproductive transition and in those years that might be highly impactful.
And even, you know, thinking of it from the other perspective as well, even the result of a successful weight loss can lead to pregnancy. And, you know, we've experienced that with bariatric surgery in adolescents. That's a side effect. You know, they lose a lot of weight and now they become fertile again and they become pregnant as a result of that. And it happens a lot more than you might think. I didn't realize that until I met with some bariatric surgeons. And it's quite an issue that needs to be addressed on that side of the coin as well. So, were there any other final comments that the panelists would like to make that came up in listening from the other presentations? We have just about 5 minutes, I think, before we definitely need to sign off here.
I will reiterate or say that, you know, I think there's a lot of interest from parents throughout Louisiana in programs, interventions, resources. And one indicator of that is through one of our research studies, we've been able to link up with a lot of the pediatricians throughout South Louisiana. And we've made it so that they just have to press a button in the child's patient chart online to notify our research team to follow up with the child related to obesity and try to get them into our obesity program. And we have had, I think, around 400 referrals just in the past 3 months from the greater Baton Rouge area, just as one example. And so I think that's exciting. Oh, Katie Queen just texted me, so I can see if I can get her question over text message. But I just think that's really promising because we're seeing the policymakers, insurance companies, the research and the parents and the physicians all kind of getting together and behind this. And so I think we've got a lot of momentum.
Maybe you could check that out. And I see Dr. Champagne has a hand raised.
Yes, I just have one question. I know that there are a lot of child nutrition personnel on the webinar, and I'm wondering if there's some things, some recommendations that all of the panelists could give to those people who are feeding the young people in our schools often multiple times per day. I think it's important that they feel like they're contributing to a healthy child.
Yeah, you know, when I have, like, if I have the opportunity to think about one kind of nutritional focus, I think about beverages in terms of sugar sweetened beverages and just, I mean, they're just so widely available. So thinking about, you know, cutting out sugar sweetened beverages, limited amounts, if any, of 100% juice, and then having water and low fat milk as being, so there's a bunch of things in there, but based on the age and based on the setting in which this is happening, whether it's related to vending machines in schools or sort of feeding young children, I would say that would be kind of the where I think focusing in on in terms of a like low hanging way to change dietary behaviors.
No, I have to agree with that I think it does start with the most meaningful way to enhance dietary quality. And that in one way is to take out the sugar sweetened beverages and to try and incorporate more nutritious and mindful eating with fruits, vegetables, and other sorts of healthier options, as opposed to just filling it with the rice or breads just in general altogether, while still learning to incorporate those types of meal programs too. So I think it's really learning the best way to nutritionally balance these meals that we're providing to children.
And keeping an advocate for the kids, you know, you know a lot, and even if you get pushback from the budget constrictions or your supervisors or whatnot, I think we have to just keep pushing forward so that we can give our children the, healthy meals and healthy lives.
And I'm thinking that happens in the schools more so than trying to pack a lunch for a child. It's very difficult to meet all the criteria that our child nutrition personnel have to meet.
Yeah, we did learn on our last webinar that we had last year from Dr. Muzaffarian from Tufts University. He did the study that showed across the US that the healthiest meal that children eat during the day comes from the school on average. They're eating much healthier at school. And we also know they actually get more physical activity on school days than they do on weekend days, if you could believe that. So, adding that structure in the school day certainly relates to health improvements. So, the school is typically focused on academic achievement, but there's just so much more that could go on in the schools to also enhance the health of the children. And I believe making that link, as Dr. Tandon does, between physical activity and cognitive performance is kind of a key to getting that message into the schools.
And I think thinking about the summer, because what you just said reminded me that there's also data to suggest that children are more sedentary, eat, worse nutritional quality foods, and certainly have declines in their academics as well. So I think programs that run through the school year, having that intentional focus on what's happening to those children during the summertime, especially those that may not have access to healthy food and physical activity opportunities in those long summer months.
Great. Well, it does look like we're out of time. Again, I'd just like to thank all the speakers and the panelists for joining us today. And we will be, as I mentioned, sending this around to everyone who registered. And we look forward to doing that. We also look forward to seeing you this fall. We actually have a treat. We will be trying to develop an in-person childhood obesity summit this fall at Pennington. So rather than doing the webinar, hopefully we can get back to real life and we can all meet together at our conference center. So we're very excited about that. So think about that for your fall plans. More to come on that. Anyway, again, thank you all very much for attending. Have a great week.